Hi, my name is Dr. Robert Kaufman, and we're about to go beyond the terminus. Today we're going to talk about resorptions, both external and internal. Resorptive lesions are some of the most misdiagnosed pathology that I see as an endodontist. Frequently, dentists will see a diffuse radiolucent area in the crown of a virgin tooth, usually close to the cement-to-enamel junction, assume that's either caries or internal resorption. At this point, some clinicians will attempt to restore the resorbed area, while others incorrectly assume that endodontic treatment will solve the problem. It's important to differentiate the two types of resorptions because understanding the source of the problem is the key on how to manage and treat them. External resorptive lesions comprise the vast majority of the resorptive lesions that we see, 80% or more depending upon which literature you read. So we're going to discuss ECIR first. External invasive cervical resorption is defined in Jeffrey Hithersay's classic paper, Clinical Radiologic and Histopathologic Features of Invasive Cervical Resorption, which you can find in Quintessence International, 1999, volume 30, pages 27 to 37. Invasive cervical resorption, what he calls ECIR, is an uncommon and often aggressive form of external tooth resorption, which may involve any tooth in the permanent dentition. It's defined as a localized resorptive process that involves the surface of the root below the epithelial attachment and coronal aspect of the supporting alveolar process, namely the zone of connective tissue attachment. Therefore, we can say that ECIR is first and foremost a disease of the periodontal attachment apparatus. Its source is in the PDL, in the periodontal ligament space, and associated with those tissues. It's not pulpally related in any way. Attempting to treat this endodontically shows a fundamental misunderstanding of the etiology and the pathology involved with external resorptive lesions and how to address them. Patients will frequently present with discoloration in a tooth close to the gingival margin. In the anterior section of the mouth, the tooth will look pink along the cement-to-enamel junction. The gingiva will frequently appear swollen and it will bleed when probed or touched. The patient will say that the area is symptomatic only when it's sore or pressed along the gingival margin. The resorption most often occurs either buccally or lingually, but as it advances, it can extend to the proximal surfaces, making clinical management much more difficult. Hithersay's paper says that although the lesions are sometimes idiopathic in nature, they're most frequently associated with either trauma or long-term orthodontic treatment, which, if you think about it, is really essentially low-grade trauma over a long period of time. In other words, the periodontal supporting tissues are placed under stress, and the cells undergo change and transformation and are triggered to respond in a clastic manner, resulting in resorption of the root surface and dentin. This is why having a history of the area and a good dental history from the patient and the referral is so important. It's entirely different from apical resorption that we often see in teeth with chronic periodontitis, which is caused by inflammation that occurs when byproducts of a necrotic pulp leak out of the foramina, or orthodontic resorption, which usually occurs at the apex. That problem, the one with endodontic byproducts and entirely an endodontic problem, is treated with endodontics. In the initial stages of ECIR, these teeth may be asymptomatic and not picked up until the resorbed areas are seen radiographically. Depending upon the extent of the resorption, thermal tests will most often reveal a pulp that's vital. However, this depends upon how much of the cold or heat stimulus can be transferred to the pulp through the resorbed part of the tooth. The most important thing to recognize is that this is not an endodontic problem, though it occasionally does require elective endodontic treatment in order to manage it or address it. The first step in assessing the tooth is to try to get a good 3D image, which most often means that a cone beam tomograph is necessary. The CBCT image can clearly outline not only the position of the resorption, but the extent. The radiographic appearance usually is characteristic, and the outline of the pulp space is frequently seen as a ghost image delineated by a thin layer of dentin. This is because the predentin around the pulp chamber appears to be resistant to the resorptive process for reasons that we really still don't understand. Histological evaluation of area shows a distinct ring of predentin around the pulp space, as shown in the article by Hithersay. The prognosis of these cases depends entirely upon the extent of the resorption. Hithersay classified them into one of 4 classes, and his classification is probably the most common. Class 3 and 4 generally involve extensive amounts of tooth structure that is frequently too great to be able to be repaired, and those teeth often require extraction. Again, this is best evaluated with cone beam tomography. In our next video, we will examine some of the methods to try to deal with such resorptions. Remember, when we do the right thing, we both get better, patients and clinicians. Thanks for watching. I look forward to our next trip when we go beyond the terminus. See you then.